Thanks. I was just telling Lakshmi, so I have two of my residents with me here today. My former residents who are better than me now. But the greatest happiness that a teacher can get ever is to do a talk along with the students or ex-students. So I was telling Lakshmi that next year you need to be part of this trickle bandi, right? So quickly, how do you work on beta cells? So remember this morning I talked about it. Those of you who were there, there's an alpha cell, the beta cell, a delta cell, but also the duct. They're all. If you look at it from a embryological perspective, right? Remember that they come from the endoderm. Then they develop a marker called NGN3. Once you have NGN3, then you become a pancreatic cell, and you're capable of making hormones. And then you have a protein called PDX, and that PDX converts them into pancreatic endocrine cells. You have ARX, you become alpha cells, and if you have PDX4 and the others, you become beta cells. Right? Just remember this, we'll come back to it. Now, what we know is that none of these cells are like us. After a certain age, we don't bend. We change when power comes to us, when money comes to us, our egos change, but we generally don't change. But nature has intended for cells to change. They can change. That's why I keep telling men, don't take this for granted, because at some point of time, nature can reproduce without men. You just need women. So what are the therapies for diabetes? One, you can replace the hormones, you can replace the cells, you can regenerate the cells, right? How do you replace the hormones? You can give insulin by a pump. You're already giving insulin by other means, but you can also give insulin and glucagon. One of the greatest inventions is the bihormonal pump, which people don't use much, but the bihormonal pump takes care of it. Second, you can replace cells. How do you replace cells? You could do islet cell transplant. Don't do it. The Edmonton protocol is the worst protocol that's ever been written in the world. You can quote me on this. Why? You need 2 donor pancreata. You need continuous immunosuppression. It is insulin dependence for 5 years. Lifelong requirement of donor tissue. And that is why the only indication for islet cell transplant today is still a combined kidney islet transplant, or in someone who has such tremendous hypoglycemias that you need an islet cell. So don't do it. So this is how pancreatic cells. So PDX becomes a pancreatic cell, NGN becomes an endocrine cell, ARX becomes alpha cell, this becomes PAC cells. Now what we know is that every cell in the pancreas is capable of making every hormone. If this is a antibody thing, looking at the precursor molecules, and you will see that every cell is capable of becoming another cell. But then why can't we just make beta cells? That's because not so fast. Nature has evolved mechanisms that are so adaptive that that's very difficult to reproduce. One, the beta cell makes about 200 to 250 units per day. Half a gram of endocrine tissue can grant lifelong glucose control. Just need half a gram of tissue. A lean sensitive adult requires about 0.5 units to dispose of oral glucose load of 75 grams. An obese insulin-resistant glucose-intolerant subject requires 45 units to perform the same task, a 100-fold increase. And for the majority of people, except the 15% of our population, or 18, it's become 20, that are diabetic, the rest of them are able to remarkably adapt. Sumit talked about it, I'm not going to get into it. Ultimately, what happens is that there is a change inside the adipocyte, there's insulin resistance, the mTOR pathway gets activated, cells go to the bone marrow, the CC positive cells come into the abdomen, they undergo a jugalbandi, and adipokines and cytokines are produced, the fat becomes ectopic, whereas Usha Ayagari, fat becomes ectopic, the ectopic fat gets into the liver, when the ectopic fat gets into the liver causes insulin resistance, the fat goes into the pancreas, it causes diabetes, it goes to the heart, it causes heart disease. This is the pathophysiology of diabetes. Mark Dornett, great guy, in 2008 showed that islet cell inflammation occurs. The first demonstration of it. So what happens to the beta cell? One, you can be born with low number of beta cells, right? Second, they can stop making insulin because there is ER stress, oxidative stress, pancreatic, peripancreatic fat. Then, as I talked this morning, that during these times, pancreatic cells can trans-differentiate, right? Three things that can happen. Now, Butler, as usual, mixed up these issues in 2004 by talking about beta cell mass. He basically used people who had died with road accidents and others, looked at autopsy series and showed that you had low beta cell mass and diabetes. But when you look at it, you take fresh harvests of pancreatic cells, you will find it doesn't stain for Congo red. It stains for insulin, glucagon. The glucagon stain and the glucagon stain increases, the insulin stain decreases, but the cells are not actually dead, which means that there's not really loss of beta cells. This is a slide that I've used for many years. It shows that the islet cell insulin content comes down, the alpha cells increase, the beta cell staining goes down, but really what is happening is it's transdifferentiation. This morning I talked about it. I've talked about it probably 500 times everywhere. What really happens is this protein called FOXO. FOXO goes into the nucleus. It activates the Modi genes, and then at some point of time, the FOXO, the cell transdifferentiates, right? So it becomes an alpha cell or a Grelin cell. Think of it as cardiac hibernation. When you have a myocardial infarction, what happens is, remember, that's why we use nuclear medicine scans. It will tell you that there is dormant tissue. So think of redifferentiation as a dormant tissue, and we know that it happens in this thing. So can you regenerate cells? You can make them proliferate, you can make neogenesis, meaning create new beta cells, and you can do transdifferentiation. Right? How do you do proliferation? Remember, proliferation already occurs in people. That's why you're born. Women have the inherent ability to proliferate many things, but also beta cells. During pregnancy, other stressor events, there is this thing. What happens normally is that the adult cells have cell cycle inhibitors that prevent the cell from proliferating. Right? Insulin resistance, but beta cells also have an inherent mechanism to prevent cell proliferation because you don't want an out of control beta cell. You'll have hypoglycemia. But that's where it comes. What we didn't know is that that allows beta cells to regenerate. Right? This, when you use Harmin, this is the adult human cells, you give Harmin and a TGF beta inhibitor, you can have beta cells proliferate. Again, great promise. This is something that's undergoing clinical trials. We should have some data on this. So this is Harmin. The second thing is, and this again, I don't want to get into too much of it. This is how it works. The second thing is neogenesis. This is something that's going to be very difficult. That is, creating new beta cells from precursor cells. There are precursor stem cells. People have tried infusing stem cells into the body. All it does is give a lot of money for the stem cell company. It has never worked. But you can transdifferentiate. Transdifferentiate using other cells to beta cells, stem cells to beta cells, and small molecules. Now remember, why is it so difficult? It's easy to change a cell, but you need to create the scaffold. You need to create the matrix. You need to create the vasculature. You need to create the distribution. It's not like just randomly throwing cells. Remember this morning I showed you how the alpha cell and the beta cell are intricately linked. Despite this, there is some progress. Right? So you can induce pluripotency into stem cells or into embryonic stem cells, which we don't use much, and convert them into beta cells. And these are now being used. Now using this, there are already in phase 3 clinical trials, this thing, and this is the Encapta drug delivery system. The problem with this is that if you bring in beta cells and push it in the pancreas, the next moment, the body's immune system is going to take it away. Why? Because it sees it as foreign. So what you really wanted is to implant it under the capsule of the kidney in a tea bag like system where immune cells don't get in but insulin gets out. So that's there in clinical trials. We're already there. It's working. The second is what I talked about this morning. I talked about Achilles' work where he showed that you can convert a ductal cell into an acinar cell into a pancreatic cell, an alpha cell into a beta cell. You remove ARX, alpha cell becomes a beta cell. Correct? What we now have is something called small molecules. These small molecules are used, but just to show you, you inactivate ARX. In the abdomen, if you knock out FOXO in the intestine, you can convert intestinal cells into beta cells. But now we have these small molecules. One is harmin, I talked about it. This is iodotuberculin, there's TGF-beta, there's leukostatin. Each of these are able to go into other cells and convert them into beta cells. Great promise. Another 5 to 7 years, we should be able to see some of these. Right? So this is how you take care of beta cells. You don't want to get there, lose a lot of weight. Prevent adipocyte dysfunction. Otherwise, you'll have to keep calling me to give such talks. So with this, I'm going to call Samit. We'll do a discussion. Thank you so much. It was fun.